This is always one of my favorite meetings to attend, and very honored to be here. Just love the work that is going on with MPN Voice, with the MPN community here in the UK, the wonderful work of the physician leaders as well as the patient advocates working together. It's very, very productive. It's very inspiring. It certainly helps to make a difference, really advance the dialogue around MPNs really around the world. Indeed, this day follows up an exciting day which occurred yesterday with many of the consultant hematologists from the UK, particularly those with an interest in MPNs here in this very room with similar sorts of discussions. So really wonderful to be here. So it's now a couple years since I moved to the great state of Texas, which I find for many in Europe, it conjures images of cowboys, large things. Unfortunately, perhaps George W. Bush, but with that, there's one thing that is difficult to convey to Europeans, and that is the scale of the state of Texas. So to give you just a little bit of a sense as to what happened if Texas were to land on the continent, it would be substantive. But it's a wonderful group of people, about 30 million in the state of Texas. And there I'm currently at the Mesa Cancer Center. So this is, we care for about 4.9 million individuals in our region that are involved or develop cancer as the academic center for that region, focusing on a deeply committed and patient-centric mission around cancer and blood issues in our community, the biology of cancer and blood diseases, trying to advance therapy, and we focus on our patients. So today, Dr. Harrison asked me to really cover improving outcomes. And truly, as I think about a topic like that, there's a variety of levels to it. Is it a better outcome to live longer? Yes, clearly, without question. Is it a better outcome to potentially eradicate a disease? Without question, that's one of our goals. Is it a better outcome to live better? Absolutely, it should be. Is it a better outcome if we learn more about what we're treating and why? Without question. So I think there's a variety of layers to it, as you've heard the wonderful talks throughout today, kind of dealing with different aspects of it. Is it a better outcome that all of you gather here as a community to learn from each other, to realize that you're not alone, to hear from speakers with a range of different experiences? Actually, without question, that is the case. Patient meetings like this have an impact. We once did a study, ran a MPN meetings, but then a larger meeting across diseases for 1,000 patients. And we asked the question, well, what is the impact of having a patient educational event? And we consented the patients that participated. We did questionnaires at the time of the meeting with follow-up questionnaires, and were able to demonstrate improvements in understanding, decreases in anxiety, and better senses of community that were durable at 3 and 6 months. So there is an impact to attending. Now, the MPNs you've heard are a group of diseases that have many different potential impacts. But one of them is the potential of evolution. Indeed, at one of the breakouts in the PV session, we were talking a bit about this, and they were to ask, what do we know about the disease progressing? This remains probably one of our greatest unmet needs as a field. We need, through research, through further breakthroughs, to understand why is it that some MPN patients progress, and why is it that others do not? How do we measure that? And how do we better design therapies to try to ensure that you are one of the individuals that does not progress? Now, we've learned many things over the years, but one is that your experiences with an MPN are quite heterogeneous. As I look around the audience, there's many different life experiences, ages, cultural backgrounds, family history, personal choices, level of fitness, diet. All of these are differences, and all of these tell us that, again, as you have a disease like an MPN does not define you. It's just one aspect of your life added with many other things that comprise, who you are as an individual. Even MPNs themselves really affect people in different ways. There's some people that have risk of blood clots and bleeding. Some people have had many, others will never have one. There is the potential of low blood counts. There is the issue of the enlargement of the spleen, very problematic in some, not an issue in others. There's the risk of progression. There is the impact of disease-related symptoms, which we'll discuss. And then there's the issue of your baseline level of health. All of these are at play. We can have someone in their 30s that has many of these difficulties. We can have someone in their 60s who hardly realizes they have the disease if their doctor did not tell them. So it's quite a heterogeneous walk. Now, we've learned along the way with studying with Dr. Harrison and many other colleagues the issues of symptom burden in this disease. We know that fatigue is the most common symptom, and then, this is really small here for me with these glasses, insomnia, sad mood. You laugh, but sometimes I just think I need to get more and more powerful glasses. Either that or a bigger screen. But next, you can have concentration difficulties, early satiety, inactivity. What you're seeing here is the decreasing likelihood as well as the lower percentage of people that have them. There are issues of intimacy. This is a very common difficulty. I view this as a secondary effect, meaning if there's a variety of things that are troubling you, typically it impacts intimacy early in that process. Likewise, people, if they are overall feeling well, intimacy in whatever part that should play in their lives typically tends to improve. There are night sweats, dizziness, abdominal discomfort, bone pain, headaches, abdominal pain, cough, weight loss, and rarely fever. Now, these are patterns, just like there are genetic patterns that can occur with the disease. Not everybody has all of these. Fortunately, some people have none of them. What we have learned as we try to improve outcomes is that these symptoms are a clue. They are a clue with the biology of the disease. We've learned that having these symptoms wax and wane as we walk a course of the disease getting better or worse, as we have impact of therapies that are beneficial or symptoms which are not beneficial. So again, we walk a course with the disease with varying symptoms. Now, as we've studied symptoms, at least my group, trying to understand, one, how it impacts how you feel, but two, how does it help to improve both the medicines and non-pharmacologic ways we deal with the disease. We've learned that inflammation is an aspect of having a myeloproliferative neoplasm. Not inflammation necessarily in the traditional way we think of it in lupus or rheumatoid arthritis, but that there's a variety of things that are active within the body that correspond to these individual symptoms, and that the symptoms are not just random, they are real. As there was a lovely discussion yesterday regarding the fatigue project and the burden of fatigue in patients with MPNs. The fatigue is at least in part, a chemically driven effect that is quite distinct from the process of just being tired at the end of the day or at the end of a period of physical exertion. It's actually a sign of the illness. Now, what we have learned is that each of these symptoms is both potentially linked with different aspects of the disease. So if you have fatigue, part of it may be the inflammation with the disease. Part of it may be the medication that we started to lower your counts may be adding to that fatigue or not. We may have you be iron deficient because of the venesections that you've had. That may worsen the fatigue. We've also learned that there are proteins in the blood, cytokines, that are linked with these aspects of fatigue, and they potentially can improve with therapy or other difficulties. Similarly, there are derivatives between a symptom category like abdominal symptoms, how that impacts people, what are the pathways involved with leading to that symptom, and what are the cytokines tied with that. So I work very closely with my colleague in Texas, Ruben, who has really been a diligent MPN investigator now for over 10 years. And Ruben is focusing to a great degree on this issue of the biology of symptoms. What does it tell us about why you have the disease, how you respond to therapy? Yes, can we improve the symptoms, but how do we leverage those clues to improve the treatments that we have? Similarly, there are additional symptoms such as fevers, chills, night sweats. They all have different implications, as well as clearly weight loss. That is a complex side effect of myelofibrosis and fairly limited to myelofibrosis. There are symptoms from having the blood counts be too high. So if I think of symptoms and timing, weight loss occurs in the myelofibrosis end of the spectrum. Symptoms that relate to the blood counts being very high, difficulties with concentration, erythromelalgia, complex headaches, those are associated with impedance in blood flow and the subsequent results people have. Now, as we think about therapy, how do we improve our therapy? Well, first, really, what is our baseline for that therapy? What are the gaps? We have wanted to clearly know more what are the drivers as to how physicians prescribe medicines for MPNs, as well as what are the goals of patients who receive these medicines. Dr. Harrison and I had been involved with landmark studies, doing questionnaires both on patients and physicians, first in the US and then in the UK and in other countries. And we found that there was both similarities, but there were some differences. In particular, that yourselves as patients, clearly the issue of avoiding progression is something that is very important and 100% understandable. Avoiding progression is key. In most individuals, if their disease did not progress, they would live out their normal lifespan. So progression is very key. Ironically, as physicians are typically taught, they are taught to primarily focus around decreasing the risk of blood clots and bleeding. And their focus on avoiding progression is less. Now, part of that is secondary to the limitation of the medicines that we've had. But there are somewhat different goals between the two groups. Now, as we think about treatment goals, it's very important as you try to have a conversation with your consultant hematologist, as I try to have with my patients, if we're doing a therapy, whatever that is, what is that the goal of being on that therapy? Likewise, if someone has is on a blood pressure medicine, the goal is to lower the blood pressure. Well, to what number are we shooting for the blood pressure? Do I need to remain on that blood pressure medicine? Do I need to do anything else to improve my blood pressure? The same is true with things like an MPN. So are we trying to avoid thrombosis or bleeding? Are we trying to improve symptoms? Are we trying to increase your activity, decrease your spleen, improve anemia? Are you trying to prevent progression? Are you trying to live longer? All of these are potential goals. And it's important to understand if you're on a therapy, that could be phlebotomy, that could be aspirin, that could be yoga, whatever that is, what is the goal of that? How do we assess whether you're achieving that goal? And if that goal is not achieved, how do we change that? Indeed, managing an MPN, that relationship between yourself and your consultant hematologist over time is an important relationship because these are diseases that have a long time course. Myself, as a hematologist, that's one of the most rewarding aspects of caring for patients with MPNs. We develop good relationships over the years, people that I enjoy seeing, learn about them, learn about what's important to them, and try to help them over the long course of a disease. And that's deeply rewarding. It's dramatically different than other very noble pursuits like emergency medicine, but where you meet someone and then you won't see them ever again. So that course is very important. Now, over time, we know that early in that course, the blood counts can be high, symptoms can be present throughout, but their character can change. There can be risk of progression, but typically in individuals that have had these diseases for a while, typically 10 years or more, as well as a risk of vascular events. Now, the question came up earlier about the issue of guidelines. And guidelines, again, frequently are made up by a bunch of folks around a conference table making up the guideline, hopefully with evidence, usually with a fair amount of opinion brought into the mix. Now, there's the guardrails of that treatment guideline. What is the science? And then the art of medicine is how one navigates that. So if the options are hydroxycarbamide and interferon, what are the aspects that one might choose in between those? If someone said, well, I want to give Avastin for essential thrombocythemia, the pharmacist would tell me, no. That's not in the guideline. I can't just make that up and just choose to give that. Now, you've heard wonderful talks today that really detailed how do we try to navigate managing ET, developing a treatment plan, come up with a frontline treatment, a second-line treatment. We know there's gaps. What is that best frontline therapy? Is it hydrea? Is it interferon? Is it something else? How do we prevent disease progression? Should JAK inhibitors be used in ET, and in whom? PV, similarly, we have a pathway that has been worked out with a series of questions that are similar. What should we use first? How early should we use that medicine first? How do we prevent disease progression? Should we consider earlier JAK inhibition, as Claire and Jean-Jacques had mentioned in the Mithridati trial? What about myelofibrosis? You heard wonderful talks today that also then balance against the issue of should we pursue stem cell transplant early or in a secondary setting? And in our field, there are many questions that remain. What is ruxolitinib failure? We have one approved therapy. How do we judge it? And who is still benefiting? If someone has no longer benefiting from ruxolitinib, what else should we use? Indeed, when we only have one option available to us, failure is always dependent on what is the other option that you have available to you. Is that a clinical trial? Is that changing the dose? Is that coming off of the medication? Or are you better off being off the medication altogether versus being on it? My goal as a hematologist is to give us more options, realizing even if this room was only patients with myelofibrosis, even if I had the best drug in the world, it's not going to work for everyone in the room. And some people, it may work great. Some people, it may work less great. Some people may have side effects. So the more options we have, the better off we are. There's an additional option now approved in the US, likely available clinically here in the UK in the future. There have been trials here. There's probably some sort of open access phase 2 study open at the time with the JAK inhibitor fedratinib. This is a cousin of ruxolitinib, but Dr. Harrison and I have actually helped to lead some of the key efforts with this. And we found, one, it's a drug that can be used in people who had ruxolitinib before, so that is helpful. And second, it can be used in individuals that have a low platelet count. Now, we've heard a lot about different therapies today, and there's a few things I'd say that we know as a field. One, keeping the hematocrit well controlled is key. Two, and these are my own personal editorial comments, but of course I have the podium, so I can do that. But hydroxyurea, has the strongest medical evidence in ET. It has good medical evidence in PV, and in myelofibrosis, it probably has the most modest role. Third, interferon is safe and effective in PV. There's less data in ET, and even fewer data in myelofibrosis. Anagrelide can play a role, but frequently it's a complementary role. Ruxolitinib has had a big impact, but we need to expand on that experience. Fedratinib is a helpful addition in the approval. But the therapy for deeply blocking progression and or the therapy of accelerated or blast phase disease are probably our greatest unmet need. So what comes next? Well, in my day job, I oversee all efforts related to cancer at my institution: surgical, chemo, radiation therapy, pathology, imaging, etc. So I think with a little broader box, and it's fun and exciting in that you learn a lot from different disciplines getting together, different diseases. We learn things from animal models of children's Ewing sarcoma that we might be able to apply to lymphoma. We might learn things, there's a JAK inhibitor grant that one of my mentees just got in lung cancer in combination with different inhibitors for refractory third line for lung cancer. So there's a lot of cross-pollination that can occur. And there is a revolution that is occurring in solid tumor cancers that I think will be coming to play in heme malignancies and MPNs in the future. It's not here yet, but it is coming. And that is really trying to alter the impact of the immune system to be able to better target the affected diseases. Now, part of the challenge that we've had, as I'll share with you, is that in the diseases where immune therapies have been the most beneficial, the affected cells are the most different from the normal cells. In MPNs, part of the challenge we have is the disease that are affected, which are the stem cells within the bone marrow, are very similar to the stem cells we need to create our blood normally. So there's a technology and a scientific advance that needs to occur. But what we have learned is that immunotherapy has made a huge impact because of its specificity, meaning rather than attacking all cells indiscriminately, they could target very individual cells. So now there are many diseases: kidney cancer, lung cancer, melanoma, prostate, lymphoma, myeloma, where drugs that just ramp up the immune system, just get it going, called PD-1 and PD-L1 inhibitors. They ramp up the immune system figures it out. Much brighter than any of us. It has made a difference for diseases that we really did not have effective therapies for. So they've really made a tremendous difference. Now, we of course took those same drugs, and there have been trials giving those exact same drugs to patients with myelofibrosis, either straight up or in combination with ruxolitinib. They've not been overly beneficial. But we're now looking at that, trying to figure out, okay, well, why was it not beneficial? Is there something else that is blocking that potential response, and how do we get around that? So a lot more will come from this immune-based therapy over time. The second is something that you probably have heard about on the news or in the newspaper, that is called CAR-T, or chimeric T cells. These are T cells that have been engineered, they're immune cells, to go after a specific marker on cells. And they have been the most effective so far in refractory acute lymphocytic leukemia, lymphoma, and myeloma, and now are approved for a couple of those reasons. They've made a big impact. Now, in myeloid diseases like the MPNs, this again is a technology that's coming, but it's not quite here yet. They can do this, but the similarity of the MPN cells to the normal stem cells in the bone marrow limit its ability to be used, but it will be coming. The third are new targets. So you've heard a lot about JAK inhibitors, but there's other drugs in development, many different pathways that are under development with trials at the moment. I won't go into them in great detail, but to share with you that clinical trials are an important way if your doctor thinks that you're not having the optimal response to the therapies that we have, that we're trying to improve that further. So Dr. Harrison and I went to an obscenely early 6:30 a.m. meeting this morning about just one of those trials, but again, either alone or in combination with JAK inhibitors, but trying to move the needle further as it relates to response. It shows you here just a small sampling of some of the different trials. You see almost a dozen presented at the American Society of Hematology looking at different combinations. You heard about some of these earlier, the MDM2 inhibitor idasanutlin, I believe was raised by Dr. Mead, that is targeting one of these pathways and has shown some benefit. I myself participate with the MPN Research Consortium. This is a US-based group now that does basic science around 3 different aspects of the disease and then creates clinical trials to try to address those gaps. Now, people have heard about CRISPR. CRISPR is a way to edit genes or try to correct genes. Now, as you might imagine, this is more complex than it sounds. And the good news is that it can be achieved. It has been used primarily in the lab. It now has been started in clinical trials for sickle cell anemia in the United States, and I believe here in the UK is part of that study as well. So we're learning about that. But in MPNs, you've heard a lot about the genetic complexities of this disease. And so we'll have to first see, can we get these gene editing techniques to work? And then how do we best apply them? Indeed, many studies ongoing. Much will be coming. It just isn't quite ready yet. So a lot of hope, a lot of things working in parallel. While you're hopefully stable, feeling well on the therapy that you have, all of this is percolating in the background to try to make a difference. And finally, we focus on trying to bring other aspects that I shared a bit about in our panel session with non-pharmacologic approaches for MPNs. We found that yoga can be helpful. Again, this was an online trial, 2 different sets of trials, one randomized against a waitlist control. We showed people could follow the yoga. They understood it. There were no injuries. We were able to demonstrate improvement in symptoms. We were able to measure blood cytokine levels remotely that corresponded to improvements in symptoms and have trials ongoing. We have meditation studies with Calm. We have cognitive studies with something called ACT, which is an acceptance mindfulness technique that we're doing as a face-to-face intervention, but then trying to develop online modules that people could potentially leverage to be able to do these things at home. Again, mindfulness is a bit of trying to deal with feelings that are difficult to deal with. You know, there's an uncertainty that I know people in this audience face, and it's difficult. Uncertainty is difficult. And how do we deal with that? How do we compartmentalize that in a way that we give ourselves permission to put that in the back of our minds, to go about our daily lives, to be able to live our lives as fully as we can, focus on our diseases when are appropriate, put it in the back of our minds when it's necessary. We have interest in nutrition. My colleague Robin Scherber is going to be conducting a anti-inflammatory diet intervention with strong correlatives for patients with MPNs, trying to see whether by a dietary change can impact symptoms and cytokines with an anti-inflammatory diet. And along with colleagues at UC Irvine, there is a supplement trial ongoing with N-acetylcysteine that similarly has potential anti-inflammatory properties that showed beneficial activity in mice models of MPNs. So I'll leave you with the conclusions that improving outcomes in MPNs is going to clearly happen. And it's clearly a partnership between us as the medical community and yourselves as the patient community coming together. It's being innovative about trials. It's about trying to develop new therapies. It's about pushing the boundaries and being creative, thinking beyond choice of strictly medications or no medications, vaccines, immune-based therapies, non-pharmacologic therapies. So it's certainly going to take some time, some energy, some engagement, but I know together we will get there. That I very much would like to thank our MPN Quality of Life Study Group. You could follow our efforts on mplqol.com, where we have our monthly newsletters and efforts from many institutions and collaborators. Thank you.